Hello everyone and welcome. This is Mary Magnuson and I'd like to welcome you to today's webinar on emerging trends in Minnesota telehealth. This is one in a series of webinars Blandin Foundation offers for our Blandin broadband communities and open to anyone with an interest in using technology to improve community. Before we begin, I'll point to the chat box on the lower left corner of your screen. To interact with us at any time during today's webinar, you can simply type your question or comment in the chat box. So now let's get started. Again, my name is Mary Magnuson. I work here at Blandin Foundation and I administer the Blandin Community Broadband Program. Moderating the webinar today is Bill Coleman of Community Technology Advisors. Bill has been Blandin Foundation's primary broadband program consultant for a number of years. Take it away, Bill.
Thank you, Mary. Broadband I should say that rural telehealth is one of the main drivers of the need for rural broadband. From now and into the future. Over the past decade or so, we've spent a lot of emphasis trying to get rural hospitals and clinics connected. And I think that task is primarily done. And now the emphasis is more on how can people use broadband-enabled technologies to reach people in their homes so we can reduce travel times and increase access and increase the efficiency of the system. Today we have three presenters that have day-to-day responsibility for launching telehealth programs in three of Minnesota's larger healthcare networks. We have Barb Andreessen from Allina, Maureen Eideker of Essentia, and Maureen is really a pioneer on this. I think when I worked at the Department of Economic Development, seemingly 20 years ago, we might have done a webinar on telehealth with Maureen, and then Marcia Wayne, manager of Altru. And so this is just something that we think has great potential to add value to the broadband network. When we think about the cost of an ambulance to a patient's home or sending a public health nurse to a house 20 miles from the county seat, those are high costs that the monthly cost of a broadband connection is much lower than either one of those. So we see this as a great way to help justify public investment in our broadband network. Marcia is going to be our lead speaker today. And Marcia Wayne is the manager of telehealth and regional services at Altru Health System. She's been employed at Altru for more than 28 years in therapy services, regional development, and telemedicine. For the past 9 years, she has focused on implementing telehealth into the care delivery system at Altru. She currently serves as the North Dakota Health Information Telehealth Work Group co-chair, is an advisory committee member for the Regional Telehealth Resource Center, GP Track, and chair of the North Dakota Board of Occupational Therapy Practice. Welcome and thanks for joining us, Marcia.
Well, thank you, Bill, and I certainly enjoy being here with you and the members on the call today. I think you'll find that the three of us like nothing more than to talk about telehealth and how we can bring healthcare closer to the consumers that are looking for that service across both North Dakota and Minnesota. Okay, give me just a minute. Let me tell you a little bit about Altru. We sit right on the border of North Dakota and Minnesota, and we reach across. Most of our clinics are actually located in Minnesota, but we serve a wide area. And on the map here, you can see the catchment area of which we serve. Many years ago, when I started in regional services, one of the first things I did was do a survey of how the inpatients that we served in our tertiary care center, and found that half of them come from outside of Grand Forks, East Grand Forks, and that was a little bit of a wake-up call. We have to realize when we serve this area that we are serving the majority of very rural people who wish to remain in those small towns and farmsteads or rural areas. All of our patient services, whether it be to the clinics, to the rural hospitals, to schools, to the patients' homes, relies on connectivity. and that means very fast connectivity, because we've all gotten very used to having response times that are responsive and that we like to work with. So clinical services nowadays depends on that connectivity. Altru has 11 rural clinics. We connect with 15 critical access hospitals, and we have a variety of other services, I think, that'll be in the next slide. So let's just go on here. But Altru has established a support network for the regional healthcare, and we don't own other hospitals within this area. These hospitals are independent, and that's 8 regional critical access hospitals. We actually provide the electronic medical record for, so they sit on our platform. And it's very important, again, that there's very good connectivity between us for everyday care of all the patients that we serve together. PACS hosting and teleradiology has very big files. So those CAT scans of CT scans and MRIs, they're very big files. And once we start sending them across the internet, it bogs everything else down. The ladies coming behind me with excellent presentations, Maureen and Barb, will tell you that the first thing that's going to fall off the internet is a video connection. And that is something that we really do not want to have happen. Some of the other regional services that Altru provides is telepharmacy, where we review first-time meds given at the critical access hospital bedside, telestroke care. Altru has 3 regional dialysis centers, hour and a half away from us. Again, that we depend on telehealth to support. Regional home care and hospice in the home. We have video and remote patient monitoring connections. And regional therapy services, that we have therapists traveling across the region to provide services in homes, long-term care centers, hospitals, etc. And remote patient monitoring is something that I think Maureen will go into further, so I'm going to let her delve into that a little bit. But all of these services have now become kind of a standard of care. This is how we provide care across the region. So according to HIMSS, which is Health Information and Management Systems Society, network reliability and availability are really key contributors to successes at the rural healthcare organizations. Larger organizations are looking to leverage that remote exam and consultations to make things efficient, to provide the care, to stay connected to the patient and to the regional healthcare provider. So that broadband is something that we're reliant on, and it is really found to be a social determinant of health. If we have rural patients out in the rural area that could be connected to health providers and are not because of lack of broadband, everybody's at a disadvantage, and they will not receive the health care that they possibly could. So the connectivity that we are dependent on really advances. We used to call it the triple aim. Now it's the quadruple aim of patient care. And this is a focus for most healthcare facilities nowadays. We are looking at the patient experience. We are measured on it, actually. Population health, how well are we keeping our clients? The care team well-being. It's important that we maintain employees and our providers. And physician providers are getting more and more difficult to position in the rural areas, as well as reducing costs. We're all functioning on less and less dollars. So telemedicine specifically really is driving that organizational strategy to improve the connectivity. It's very important that this be a part of that patient experience. And Barb and Maureen will agree with me that we know this improves the patient experience. We can deliver care directly to the patient and have it be more timely and have it be quality care. We tap into previously unavailable experts to drive evidence-based care, as well as reducing costs. And we know that patients have choices. Patients don't need to connect to the hospital down the street or where their doc they've always seen, that there are commercial vendors that are within our neighborhoods and in our networks that can provide care. A mobile picture and a connection over a mobile device or online can get you a care provider to see the great majority of the needs. And so expanding technologies is very much a focus for all of us, for rural facilities, rural patients, and the larger healthcare systems. And this is where we live, isn't it? Especially today. It's a very stormy day up here in northern areas. We have clinical shortages. We have misdistribution of providers. We have specialty providers sitting in some areas and not others. We have urban and rural underserved, but don't hesitate to understand that there are urban folks down the street that are underserved as well. We have a very large aging population. Travel time, costs, and hardships delays treatment, and now that only does is increased healthcare costs. So these are our realities. Some of the barriers to services in providing, especially telehealth services, in overcoming that network connectivity issues is the implementation cost and just the lack of services to the area. And so as I was looking for this, I found this online and I thought this was kind of interesting. There's the state of Minnesota is very well organized, of course, and then there's this map and it says this is the broadband availability in the state of Minnesota for houses served by wireline. And on the left is 4 of the counties that we serve in northwest Minnesota. So 34% of the houses in Marshall County have wireline broadband service. So what that tells me is that I can, here at Altru, have great telehealth service, provide health care to the home, but if I can't reach that home and I can't reach that mother who sits with many children at the home who needs connection to a physician or services from therapy or whatever, I can't deliver that health care, and nor can she receive it. So it's a very important piece. When we talk about telemedicine today, we're going to be talking about the interactive audio-video communications technology used by healthcare provider or healthcare facility from one site to another. This is delivered over a secure connection that complies with the requirements of state and federal laws. At Altru, our telemedicine strategy really is to efficiently provide services using technology that's available to increase access and improve health. And just to give you, again, a little bit of a scope, in next year, we will we have smaller clinics in Fertile, Erskine, Red Lake Falls, and they connect to a hub in Crookston. And we've had providers going out to serve these clinics, and we're having difficulty maintaining that service level. And we're going to switch some of that to be a telemedicine service strategy. So strong broadband is essential to the strategy, absolutely essential to the health care to those residents in those communities. We also are going to start a connection to the county jail in Roseau, and we're expanding our connections to patients' homes. And in this map, it has 2 big lines down to Minneapolis because we connect Minneapolis for burn treatment at the burn centers in Minneapolis. And it would be very difficult for our patients in this area to travel to Minneapolis for the 15-minute follow-up, visit. And so we're always reaching out to expand to the larger centers ourselves. This shows the growth of our telemedicine encounters. It's quite amazing, and it just shows us that patients want this, are looking for it, and expect it, frankly. Everything changes, and it's changing very quickly. This is showing you it's a pocket-sized smartphone that connects and will send an ECG to a cardiologist. More often we're getting this availability. Our providers are expecting it. And if they have this and we can provide it, we know that these patients are referred for care more appropriately and they experience less hospitalization or death. And of course, that's what we want for all of our community members. So economics, let's just talk a little bit about, since most of you or some of you are economic development folks, from Altru, but all hospitals. we are really looking to maintain as much utilization of our physicians that we can. So we have many physicians here that travel and do outreach in the smaller towns. And we love to do that. We think it's an important piece of care, but there's only so much time that we can do that. So if we can switch some of that to telehealth and make sure that when they do go out, they see who they really need to see in person, it's really important to us to eliminate that travel time for each specialty and still maintain that level of care. Every time that we can decrease the need to transfer patients from regional hospitals to tertiary care centers, it's a very important win for both of us, both that rural hospital where that patient can stay and the tertiary care center where that bed can go to the next patient that's in need. When we reduce the patient wait times for specialty appointments and outpatient services, we're all winning because we are reducing the cost of care. So let me give you just a quick example, and this is maybe a little confusing, but what I did is I took one of our rural clinics, and we had 1,223 telemedicine encounters last year. We got $28 as a facility fee, let's say. For each one of those encounters, there was $34,000 in revenue. And then I looked at the telemedicine patients, and each one of those that had a lab drawn at the rural clinic, it was important that we kept that income local. And we were able to do that. And in measuring that, we had $69,696 at that clinic that stayed there in lab fees. I couldn't even count the x-ray fees, but I know that we had 48 ortho patients, and each one of them had an x-ray prior to the visit. So I kind of figured out that we had $103,000 that stayed local at that clinic because of telemedicine services. And that's important. It's very important to the clinic because we're all measuring those dollars. We have 10 rural clinics. So if I extrapolated those same kind of visits out over those 10 clinics and use that same methodology of the facility fee and some lab fees, $419,000 a year was generated because we provided that telemedicine services at those very rural clinics. And that's kind of a tough thing to measure sometimes, the advantage of having telemedicine. So let's think about that skilled nursing facility where we have to put everybody in a van and drive them, 2.5 hours down the road to see that provider. What does that cost? And what about the rural critical access hospital who we take the ambulance out of town and they can't get the next patient in, or they're completely without an ambulance for that time period? Connections through telehealth for a rural health team and the families involved is just unmeasurable, and it's very important that we save every inpatient admit that we can from happening if possible. So broadband really is a life and death issue for rural America. We really rely on it these days to connect our doctors, to connect our patients to the tests that they need, and to share the information back so that the proper care can take place. That's what we're about at Altru, and today I just tried to lay the bedrock here so that Maureen and Barb can tell you a little bit more about telehealth provided throughout the region. If you have any questions, I'd be glad to answer them now or later.
Thank you, Marcia. That was really interesting to see that data on local clinics. $500,000 of revenue is a lot of money for $100,000 is a lot of revenue for a small clinic, so that's great. Our next speaker is Barb Andreessen, and she's the Director of Telehealth and Regional Development for Allina. Her current focus is development and deployment of programs and services delivered to rural communities and patients, as well as development of virtual visits for patients at home or in the office. Barb's worked for Allina for 13 years. Her previous work includes consulting and implementation for 2 healthcare software vendors. She's a University of Minnesota graduate. Welcome, Barb.
Good afternoon, and good afternoon to everyone who is present on the call. Marcia's done a really nice job of setting the stage regarding what the Altru system does in their neck of the woods, as well as the importance of the broadband. So what I'm going to do is give you just a little bit of background on who Allina is, and two programs that really depend on strong broadband capabilities. One of those programs is Telestroke, and the other program is really going to be focused on where we're heading next, which is our virtual visit to the patient's home. So I want to talk to you a little bit about that as well. Just a little bit of background on who Allina is. We are a system of 12 hospitals and over 90 clinics. We have about 28,000 employees.
Sorry.
Okay, and including pharmacies. That's okay. Pharmacies and DME and home services. We are largely based out of the metro area. Our services or our communities that we serve are in the Cambridge area, as far north as the Cambridge, to the southwest in the New Ulm area, over to the River Falls area, and then down to Owatonna. So that's really basically our broad range. We also, as Marcia had mentioned in her discussion, we have partner hospitals that are independent hospitals that have our Epic system and other services that we provide. So really quickly, just a little bit of comedic relief, I guess. This is 3 different comedic examples of how things are, progressing in this world. So the first, I think it's very funny with the lady talking to the woman in the waiting room with the camera on the head, the man who's trying to log his iPhone as his primary care physician, and then the physician that's down on the bottom, providing a virtual service to a patient who's at home. And this really is, in essence, a funny look at what our world is today. When we look at the type of services that Allina provides, I would say that they're really in 4 different quadrants. We do the outpatient consultations, acute care services, remote home monitoring, which Maureen will speak more in depth on, and then the home patient visits. So our large services are Telestroke, mental health assessment and referral. Both of those services are services provided to the EDs. Cardiology services, psychiatry, we do some outpatient palliative services, genetic counseling, primary care, established patient visits, home monitoring, remote observation, and we also do some EICU services. Our geography that we serve is depicted in this picture. You could see that all the stars on the map are the locations that we provide services to. We also just recently opened a location down in Florida focused on providing some services for patients that winter in hopes of the continuity of care from the summer up here to the winter down south. As far as our volume, you could see a very similar trajectory to what Marcia has shown. We're just a little bit behind on the encounter number from Marcia, but you could see that it is there is large growth year over year, and I think that we're on just the cusp of it growing exponentially quicker in the next year or 2 as well. From a Telestroke perspective, what I wanted to discuss is the fact that we do provide Telestroke services to all of our hospitals, as well as 24 non-Allina locations. So we provide services to 36 locations. And I'm going to speak to the next 2 slides on why broadband and connectivity is so important. We do over 1,000 telestroke encounters and have done so in the first 10 months of this year. If you think through that, that is an awful lot of patients or potential stroke patients that are being served. The goals for Telestroke are all based on time, and broadband in the connectivity in order to achieve those goals is vital. So what I wanted to show is 3 different areas of goals for our Telestroke program, the first being the door to CT, which is really the time that the patient arrives in the ED to their initial imaging. Our goal is to have that time frame be less than 10 minutes. Next goal that we hope to achieve is door to needle, and needle is when the patient has arrived to when they're providing the TPA for the patients that actually meet the ability of having TPA. For those of you who don't know who TPA is, that's the clot busting drug that helps reduce the rehabilitation or reduce the impacts of what stroke can do to a patient. Our goal is to have the ED arrival to that initiation of the TPA be less than 40 minutes. We also have a strong goal with our counterparts in the EDs at the regional locations or the rural locations to have strong virtual teams helping to increase their awareness of identifying stroke patients as well as providing follow-up visits and ensuring that if a patient can stay in the rural community that they are allowed to stay in that rural community. So the point that I wanted to bring home on the Telestroke is the fact that time is really brain in this case. So as you see in this picture, 1 minute, 1.9 million neurons in your brain. With the broadband, if your connection isn't vital enough for the stroke neurologist to be able to go through their stroke protocol or to be able to see the CT images, you're impacting the end result of a patient's care. So we really depend on those strong connectivity elements to be in place for positive encounters and results in our stroke program. You can see here that 5% increase in relative risk of mortality for every 15-minute delay in initiating that IVTPA. And if you remember right from here, our goal is less than 40 minutes from when they hit the ED. And then a 10% reduction, absolute reduction in good outcomes for every 30-minute delay in endovascular treatment. So once again, you could see how important time is in the care to time, or the care of a stroke patient. I'm going to move a little bit further into our virtual health or providing care to patients in the patient's home. Grabbed a slide from SG2, which speaks to the fact that patients are really ready for this type of service, to be able to provide and to receive service at their convenience in either their home or their work situation, and not have to go into a brick and mortar building. So 70% of patients report being comfortable communicating with their physician or their provider, either via text, email, or video. SG2 also forecasts that by 2024, 15% of all U.S. evaluation and management visits will occur virtually, and those are basically your provider, your PCP visits, your primary care visits. And then about 19% of American adults who own smartphones have at least one health app on their device. I think this is really interesting statistics when you look at what can happen in the near future and what will happen in the near future. So what Allina is doing in this particular space is we are working on providing primary care visits to patients' homes or their workspace virtually. And what I wanted to depict here is just what that looks like. In the upper left-hand corner, you could see what it would look like if you were on a desktop or a laptop from your home, and you'll notice down in the very bottom here, you've got the patient and the provider. So this would be the patient, and this would be the visual you could see of your provider or vice versa. Also, in this particular picture, this shows what it looks like when you're providing service on a smartphone. So again, it's just basically you could see both a picture and a picture, a little more balanced, if you will, on a smartphone. And then on an integrated solution, you could see what a physician or a provider would be looking at as they're charting their data in their EMR and speaking to the patient right here. So we're really excited on what potential growth elements are going to come out of this. Our primary care physicians at one time had determined that they felt a quarter of their visits could be conducted outside of the brick and mortar building. That allows the patients to be able to have convenience care, and it ensures that the primary care providers are seeing the patients that really mostly need to be seen for more chronic type cases in their offices. And I wanted to take in, spend one last minute on potential future of where we could go in telehealth. And this really is not that far-fetched. Best Buy, for instance, has a program to date that they're working on with making smart home technology and deploying that technology into the home. This type of technology will allow patients to be able to, or people, to be able to retain their residency longer than they may have currently. You can see there are things such as smart beds where they have bed sensors. You can have sensors in your toilets here. You know, the utopian component of this is that you could have sensors in checking your urine and being able to identify if something's amiss based on the urine in your toilet. You have doors, smart doors. When a patient is moving in and out of rooms, there's sensors that can provide data and knowledge to someone who's monitoring a person in their home. And then you have all of these apps that a patient can interact with, or a person can interact with people or doctors or all kinds of caregivers. All of this is dependent on having connectivity. And so for people who are currently aging, this gives them the capability to be able to retain their residency for longer than what they may be able to today. So I think this is an interesting perspective of what's just around the corner. And with that, I think I will transition it over to Maureen.
Thank you, Barb. That was great. I was just in Best Buy yesterday and saw their smart home display. That's starting to take up quite a bit of space in their showroom. So we know that things are picking up on that account. Our final speaker is Maureen Eideker, and she's RN and an MBA, and is one of Minnesota's and the Midwest pioneer in telehealth. She started her work in telemedicine in 1994 while director of nurses at Tri-County Hospital in Wadena. She's worked with many state and federal grants, such as those awarded from the Office for the Advancement of Telehealth and the University of Minnesota and the USDA Distance Learning and Telemedicine program. Since 2001, she served as the system director for telehealth for Essentia Healthcare in Duluth. Maureen has been instrumental in developing over 30 rural originating telehealth sites across Minnesota, Wisconsin, and North Dakota at hospitals, clinics, and long-term care facilities, and more than 30 specialty outreach services across Essentia Health. She's actively involved with public policy related to telemedicine and access to broadband. She's a frequent speaker and presenter in Minnesota and North Dakota related to implementing telehealth and using it to address rural telehealth access and provider shortages. Maureen is also on the governor's rural broadband task force and does a great job there, and participated in one of our projects in central Minnesota in the Region 5 area where they brought together all the different healthcare providers from county public health to hospitals to clinics and long-term care facilities, and talked a lot about telehealth in 5 or 6 different seminars across the region. So Maureen, thanks for your commitment on this, and welcome.
Yeah, you're very welcome, Bill, and welcome to our guests today who are listening and hopefully going to have some questions for us. You know, I really want to thank Marcia and Barb for sharing their experiences and some of their perspectives today. And before I start my presentation, Marcia, are you still on?
I am, yep. Mm-hmm.
Marcia, can you tell us about the big snowstorm up there in Grand Forks and how you switched a lot of patients over to telehealth that day? We want to hear a real live action story, and I know you've got one.
Well, we do. So we do have, like I said, we have several outreach specialists that go out on outreach to the rural clinics. And this week we had that snowstorm that came through. And what happens is that we want to keep our providers safe. We want to make sure that our patients are seen. So instead of having them go out on the road to the rural clinics, we flip all the appointments to telemedicine. The provider stays in Grand Forks. The patients still go to the rural clinic and they see their provider via telemedicine. And these providers are oncology physicians. They are cardiologists, nephrologists that take care of renal situations. And these patients need to be seen kind of in a timely manner based on their appointment schedules. And it works out very well. Patients appreciate it. They get the care they need, and we keep our providers safe, and we maintain some revenue. So we flipped about 70 appointments that day.
That's a great
Marcia,
story.
thanks for sharing that story. Yeah,
Maureen?
It is. And I thought for sure you'd fit it in. Yeah, go ahead, Bill.
I was just going to say, well, before you start your presentation, there's a question from Noreen Kleinfang-Wald about telehealth and the need for interpreters for non-English speakers. Anyone have any experience with that?
I can speak to I can speak to that, and Marcia and Barb probably would like to weigh in too. We do oftentimes have that third person, the interpreter, in a video conferencing visit. It's very easy to do. We just link them up, as a, just like we're on a phone conference here. You can bring many people into a video conference as well, and we just bring the interpreter into the video conference. We do use that as often as we need to in all of our clinics. Marcia or Barb, any comment on that?
This is Marcia.
Yeah, this is Barb. I would say that, oh, go ahead, Marcia.
Well, I was just going to say the same thing. We just link the interpreter in as needed.
Same with us, and I think for the most part it's done by phone. There is a lot of interest in trying to do the same type of interpreter visit via video. So we're looking at that. I think there are some cultural differences on where that would work best and not, but definitely interpreters are a vital part of these visits.
And so just to clarify, that interpreter may be at a third location, correct?
That's correct. We actually bring our interpreters during our telehealth visits in by video conference. We could bring them in by phone as well, but we actually bring them in by video.
Okay, thanks. Well,
yeah.
Maureen,
okay, very good question. Thanks. Sure. Okay, thanks a lot, Bill. And let's take a look at the. I'm trying to bring my slides forward. When we practice, Bill, I can move my slides forward with the clicker here on the.
I'll take care of you, Maureen.
There we go, on objectives. Okay, thanks a lot. Well, instead of starting out by talking about, showing some slides and so on like Marcia and Barb did, which I really appreciated because I think that they were going to give you probably a good feel of telehealth across Minnesota. Marcia representing way up northwest and Barb representing down in southeastern Minnesota more. For Essentia Health, I've been at Essentia this is starting my 7th year, and so we have across Essentia, and Essentia is located in Duluth. We have 17 hospitals, for instance, Virginia Regional Medical Center, Detroit Lakes, Brainerd, Fargo, the old Innovis Hospital was once called Innovis Hospital. So we have 17 hospitals. We have Boston and many facilities that are critical access hospitals across northern Minnesota. We have, so it's 17 hospitals. We have 70 clinics, and the clinics are in western Wisconsin, and then across the top third of Minnesota mostly, and over into North Dakota, Fargo, Jamestown, Watston, Valley City, and so on. Essentia has 17,000 employees, so it's a pretty big. It's an integrated accountable care organization, and there are 1,500 MDs and NPs providers. Now, the reason I point that out is because when I was in Wadena, I always said we're on the kind of the asking side or the begging side. You know, we need the service, but since it was an independent hospital, it was hard to have an affiliation where we could actually get those specialists to provide the services for us. Now, in Marcia's stories, you've heard that the Grand Forks physicians are the physicians that go out either in person or via video conferencing to take care of the many clinics and also long-term cares, which Marcia didn't mention. And Barb, it's the Allina physicians that are doing that outreach. Now, for the Essentia Health sites, the 17 hospitals and 17 clinics and 7 nursing homes, we are using the Essentia Health providers. Most of the over 30 programs now that we have are specialty providers. We do some family practice. For instance, one of our largest programs is medical weight loss. Another large program is child psychiatry and adult psychiatry. Cardiology is also a large program. So just a little bit of a backdrop about Essentia Health. But let's go ahead. I wanted to, in talking with Marcia and Barb and Bill and kind of planning on our program today, I wanted to review looking at home monitoring and the equipment in particular, the return on investment, and so on. So I wanted to drill down just a little bit more on what we're actually talking about here when we talk about Tele-Home monitoring. Now, with Tele-Home monitoring, as you see in this picture, the lady is in her bedroom standing on the scale. There is a little box there. That box is either connected to her Bluetooth or to her computer, and she is actually doing a daily weight. The weight goes to a central monitoring station that is monitored by probably registered nurses or technicians who are going to react to if that lady has gained a certain amount of weight that the physician is going to be concerned about. On that little screen there that you see on that box on the dresser, she's actually answering some questions. We call them daily diary. It's a daily diary log. Now, we're assuming that this lady has congestive heart failure, and we'll talk a little bit more about that. But she's answering questions like, are you short of breath today? Did you have too much salt in your diet yesterday? Do you have swelling in your ankles? So she's answering these questions as in a daily diary, but she's also learning about her disease that way, because she can see, if she's pushing yes, that I had a lot of salty food yesterday, and her weight is up 3 pounds, it's a connection there. So she will help to learn to take care of herself. Okay, so all these things are leading to the improving the health of the patient. Now here we have some devices. There's that daily diary log. And then the device is the blood pressure monitor, a glucose monitor, the scale that you just saw her standing on, a little spirometer for people with chronic pulmonary disease, and an oximeter, which measures the oxygen saturation. Now, of those pieces of equipment there, the blood pressure monitor and the scale by far is the one that's used the most. Okay, so we can move on. And we're not promoting any kind of brand, but that particular suite of devices they're called peripheral devices. They do cost. There's a cost of between probably $3,500 to $5,000 if you're going to buy all of those. And lots of times the equipment is rented or leased on a per patient per month basis. And the reimbursement by insurance is not well in place. So when we talk about return on investment, we have to look at other places other than the insurance reimbursing. But first of all, I want to give you an example. And this is probably, this is an example from back in Wadena from when I first started in Tele-Home monitoring, which was in 1998. And I just became a believer just before, I was really a firm believer in this because of this one particular patient that we had. We maintained her in her home, and she was over 86 years old. She was maintained in her home over 3 years. Where she was kind of on the brink of, does she need the nursing home or can she stay at home? We decided through home care to do daily video visits with her to help her choose her insulin injection site and to remind her to give her insulin, to walk her through the steps. So one of the home care nurses, the team, had her watching her give her insulin injection every morning for 3 years. And it saved, now she would have had to go to the nursing home, and if she would have been a Minnesota Medical Assistance patient, for instance, there would have been costs for her housing at the nursing home or even in assisted living, and we're just going to put that at $6,000 a month that the county MA would have had to pay or help to support. And by saving 36 months at $6,000, there is $216,000 just in savings in terms of the residential care. Let's go to the next one. So the example number 2 is the lady on the scale. Now the lady on the scale that we saw on the first slide, she's probably a pretty good example of a heart failure patient. Heart failure is a very prevalent disease, and so we're going to talk about it here just a little bit. It affects 5.8 million people in the United States, over 650,000 new patients annually. The lifetime risk of developing heart failure is 20% for Americans over 40 years of age. So I bet if we talk to each one of you, you would know some people with congestive heart failure. And as a nurse in the hospital for many, many years, yes, congestive heart failure is a very common disease. And it's a disabling and debilitating disease as well. Heart failure is the most frequent cause of hospitalization in the elderly over 65. Prognosis, half of the people who develop heart failure die within 5 years of their diagnosis. So it's really, it's a very bad disease. Less than 25% are alive at 10 years. So the progress of the disease means the patient is going to be going downhill unless we can do some things to help to stave that off. And that's where Tele-Home monitoring comes in. Heart failure progression is inevitable. It's not always treated correctly. Sometimes it needs more aggressive treatment. Patients don't necessarily adhere to their diet and medication regime. And projections show the prevalence of heart failure will increase 46% up to 2030. Resulting in over 8 million people over 18 years of age with heart failure. So we are seeing even younger people with heart failure as well. Next slide. What will it cost? Well, an individual heart failure patient, about $110,000 a year, and these are projections from the American Heart and Stroke Association. In 2012, total cost for heart failure was estimated to be $30 million. Projections show that by 2030, it'll increase by 127% to almost $70 billion from 2012. So I picked this disease because it's just a very costly one and a very common one. Next slide. The summary, but let's look at readmissions for heart failure within 30 days. Now, when a person has a readmission to the hospital, they're going to go through the whole cycle of, okay, they're getting sick, they have to come back into the hospital, and then that next 30 days is going to be a very critical time when, watch out, during that 30 days, they could be readmitted again. So what can we do to not have this happen? Well, nationally, 24% of patients who leave the hospital, within 30 days, they're readmitted. And that means that they have gone into congestive heart failure again. At Essentia Health in Duluth, that number is 9%. So they're very aggressive in terms of working with heart failure patients. And when they use the Tele-Home monitoring scales, like the picture you saw, then a patient is readmitted only at a level of 2%. Okay, let's go. Next.
Ooh. Sorry.
We do have foundational research that came from the mid-90s, and then the University of Minnesota replicated the research in 1998 with very similar results, and that was the research that I participated in for 8 years in Wadena, and so that's why I've been into this for a long time. The VA in Florida experienced even a greater impact by adding care coordination. That's nurses that help with making sure that the patient is understanding and being compliant and so on. And then Essentia Health conducted research under a Beacon grant that just ended like 2 years ago with similar results and added self-management education. Remember I talked about that daily diary log? Next slide, Bill. The University of Minnesota research in 1998 and 2004 showed the impact of using home monitoring devices on transfers to higher level of care, and also the patient's ability to use and accept Tele-Home monitoring equipment. Okay, next slide. And there was a research group of 150 people. Let's look at that again. Next slide. And there was daily recording of these different vital signs and video visits that were included on this. And the group was limited to congestive heart failure, diabetics, and pulmonary disease patients. Next slide. And here are the outcomes. So this is why patient monitoring is such a big deal, is because in that control group, and the other places got the same, the other research got the same results, the control group went to a higher level of care, which was either the ER, the hospital, or long-term care, at a level of 42%. But those that had Tele-Home care, the Tele-Home monitoring, went to a level at only 17%. So 17% versus 42. The Beacon case study, and this is just a very good example, quick, a 53-year-old female with more than 6 chronic conditions. She had 13 hospital admissions in 2011, costing $156,000. Now, of course, that'd be a lot more expensive in today's market. Remote monitoring and self-management conducted, resulting in, after 1 year, or during the next year, 1 ED visit and 1 brief hospitalization, costing $2,500. So look at the difference in that. And, you know, for the county and economic development people that are on the call, that's the way that Minnesota medical assistance has to be supported. That's a lot of money, and it's a big difference, and a reason that, I mean, that is the ROI on Tele-Home monitoring right there. In addition, some of the things that Marcia talked about too. Okay, next slide. The Veterans Administration in 2004 put together a similar program and research, and they saw a 50% reduction in hospitalizations. Their research was including diabetes and I think mostly heart failure patients. They saw an 11% reduction in ED visits. Okay, next slide. Oh, excuse me, here I have to sign in here. Drop off. The return on investment pieces are just so very interesting, I think, but they are hard to actually sell when you're talking about, how do you actually get the reimbursement for the equipment and that kind of thing. Excuse me here, I have to sign back in. Okay, thank you. At Essentia, we currently have over 300 home monitoring devices out just for heart failure patients. And we also have the very sickest patients who are in our healthcare home and hospice, home care and hospice, using the home monitoring devices, mostly the scales, a little bit of blood pressure use. The heart failure program started using the devices early on and were named a best practice example by the National Quality Organization. And the readmission rates in this group are like 1 to 2%, when the national average has been over 23%. That's mostly scales. And they don't, now a person may keep them for years, or they may keep them for, let's say, 90 days, or a 1 year period or something like that. Each patient is different in terms of how long they keep and use the equipment, where the results get downloaded. Okay, next slide. And I'll kind of wrap up quick here. The heart failure program, the information does go right to a central monitoring station. If there is a problem, it is sent to the primary care doctor or the cardiologist. The registered nurse talks with the patient, interfaces with the physician. Maybe there's going to be an additional medication or something that's going to be used, for instance, with heart failure, to take that water retention off the patient's heart. Next slide. So a medication adjustment. And it's all done by monitoring and exception review. And here's a very good example of, this information is just, it's downloaded, and this is using the internet, to use this data and to actually analyze the data as well. Next slide. Advantages to Tele-Home monitoring: it facilitates early intervention and prevents ER visits and hospitalizations. There's improved patient adherence with care plans. The patient gets immediate feedback on lifestyle choices, like I mentioned, on the swelling and how much salt did you have yesterday. High patient satisfaction, healthier. That's the name of the game. We focus a lot on the provider shortage and that kind of thing, but also just the access for the patients is such a huge thing that if we can't get that access improved, it's hard to keep people, to help people be as healthy as they can be. Improved quality of life, decreased length of stay, decreased long-term care stays by, for example, that lady with diabetes that remained in her home for 3 years. Next slide. Financial considerations: county costs for MA support, especially with long-term care, decreased tax bases when people leave their homes, and decreased local spending when they really can't be out and about. Increased county costs for disability. And those financial considerations, as I'm thinking about the other two presenters today, it's not just Tele-Home monitoring that brings you those financial considerations. It's many of the things, like, for instance, Barb is talking about with Telestroke and avoiding the disability by getting the clot-busting therapy given as soon as possible. And the very good examples that both Marcia and Barb gave. I've given some references there that help you learn some more about telehealth if you're interested, especially Tele-Home monitoring. Next slide. And those were some of the references I used. And next. Now, Marcia and I are both members of the GP Track Advisory Committee, and that is Great Plains Telehealth Resource and Assistance Center. And for those of you that are interested in moving your telehealth programs along or finding out more about it, certainly you can call us. You can look at the GP Track website, and that's www.gptrack.org. And we can, help you learn more about it. I think Marcia's examples of the county jails, there's lots of savings there. And that is, some of these new markets are going to be, you know, very, very much welcomed. And now that telehealth and our broadband is improving, we can actually use, you know, provide those services much easier. So now I'm going to turn it over, Bill, to some questions, and also see Marcia and Barb if there's some comments that you wish to make if there aren't any questions.
I have a question about the, you know, a lot of the scale and the, you know, little bit of data, that doesn't really take much broadband. What do you see as the potentials when, if everyone had broadband in terms of, you know, real-time video interaction between doctors and patients, or peer groups around some of these diseases, and, you know, AA meetings online, or
yes.
What's the trend?
Oh yeah, and we see, yeah, well, we see that coming. Marcia and I had an opportunity. We work with the North Dakota Telehealth domain over there as well, and one of the people from, it was a LICSW, a social worker from way over in Williston, was at a conference we were at in Bismarck together, and she was telling us about actually this very thing, linking people that she was working with for addiction therapy from several communities, linking them together, and also maybe the provider, the addiction counselor, might have been from Minot, for instance, you know, working with patients from 3 or 4 different communities in that northwest North Dakota area. So yes, we are seeing more of that. We are seeing diabetic education. There's just a whole lot of support services that could be because of the multi-point. Yeah, so
good.
We are going to see that area growing.
Barb? I wonder if we lost them.
Yeah,
I'm on.
Yeah, maybe. I'm not sure.
This is Marcia.
Marcia, we were just talking, Bill had a question about support groups and the multi-connecting.
Yes, we are, you know, we talk about that for diabetes group education. It's still coming. You know, again, we reliant a little bit on patients' mobile devices and availability of some connectivity there yet, and it's a problem.
Okay.
And this is where we don't do any group interventions, I guess I'll call them, to date. We've talked about it from the perspective of the mental health arena. So I see something like that coming in the future. It just isn't there yet.
Okay, thank you very much.
Right.
You know, we're about at a little after 4 now, so we usually try and keep it fairly close. If there's any closing comments by any of our presenters, that'd be great to hear.
You know, this is Maureen, and probably the closing comment that I would have is, you know, as you start to think about how applications for your counties, your communities, there's lots of different models out there where, you know, there's something that might be very unique about your community that fits a certain model for telehealth, whether it's Tele-Home monitoring or, you know, bringing in certain services and helping to maintain people in their home and so on. So there's lots of different models out there, and I'd encourage you to reach out to GP Track or to Marcia, Barbara, to talk to us about it. We'd love to talk about it. Okay. Thanks so much,
Great.
Phil.
Thank you. Thank you to our speakers. And Mary, I'll turn it over to you to close.
Thanks, Bill. And thank you also to our speakers today, Marcia, Barb, and Maureen. Our next webinar will be on Thursday, January 11th from 3 to 4 p.m. and the topic will be telework, telecommuting, and home-based businesses. Thanks everyone for attending today's webinar and have a great rest of your day.
You too, Mary. Bye now.
Thanks. Bye.